So normally when you have any heart block, it's anything greater than one box that we're probably looking at. So, but like I said, depending on what book. So if you guys have your critical care book, you probably want to look at it. I think in your book it said 0.24, but I'm not sure. So usually between 3 to 5 box. So if you have a normal PR interval, then you are not in heart block. That's what it would say. Usually when you do your EKG, the doctor, your instructor or your test exam would tell you measure your PR interval. Then you have to say, you look at the PR interval. Everybody agree that PR is about 0.12? That's about 3 boxes. Remember, what's a small box is equal to?
1,500.
0.04, right? So if you have 3 boxes, it becomes
12,
yeah? So now the QRS. Now you can have a normal. Now remember, first of all, every QRS, are they look the same or they look different, right? So they are look about the same. Now R to R is it regular or irregular? What does it look like? Regular, right? So now what's a normal QRS?
What I said earlier.
Yeah,
0.06
to 0.11.
Okay, your book said 0.06? Okay. Yeah, normal, most likely we always call it 0.04, but I guess the book says 0.06. Do 0.12. Usually it's like 1 box to 3 box. If anything greater than 3 box, we call it wide, right? And they say, well, what's the downside of a smaller QRS? The problem is that when we see a small size QRS, we think it's going to go into a tacking rhythm and we'll worry. But usually we're not so worried about a small QRS.
It's an ineffective pump. It's pumping too quickly. It's not strong enough.
So that's what we worry, but usually we worry that it's too wide. And anything greater than 3 box, we call it wide. Okay? So 1 to 3 box of the interpretation, you have a normal QRS, right? What do you think that QRS would be? That's my how many boxes do you think it is?
2.
2?
Maybe.
Yeah.
1 or 2.
3. 2.
Looks like 3.
Yeah, right.
Yeah, 2.
So now, this is your normal EKG. The rate should be 60 to 100, right? Some books may say 50, but I think we're always going to be stay standard. Anything less than 60, we call bradycardic. Anything greater than 100, we call it tachycardic, right? So that is just a given fact. The PR, anything have to be, it got to be less than 1 large box. But like I said, some of your books may say 0.1, 0.22, but I would just say anything greater than 1 box. And then QRS interval right there is. But your book said 1 point.
QRS complex was 0.06 to 0.11.
1.
Yeah.
Okay. So anything greater than three little box, I would worry with a QRS. So now, why do we care? So now because when the rhythm is very important to determine your pump, right? So that's why we will look at the rhythm. It's just review for you to understand about where is the sinus rhythm coming from. Now, we're talking about the normal rhythm. Now we're talking about heart blocks. Again, the reason that we worry about heart blocks is a message delay, the communication delay. And when you have communication delay, your pump is not going to be pumping effectively. So that's why it's important that we know. So the key thing that you have to remember, first degree heart block is the simplest thing. Like I said, when you look at the PR interval, they all should be the same, and all the P should be the same. All the P should come before the QRS. The only thing that said is first degree block is bigger than 1 box, 1 big box, right? Or longer than 0.24, right? So that would be the first degree heart block. And again, the only problem with the first degree heart block is because the communication takes a little bit longer. And do we treat the first degree heart block? Most likely we don't. We only observe. If the patient starts having symptoms, then we got to do something about it. Well, what do you think is the most common cause of the first degree heart block?
Like a bundle branch block?
No, we're talking about first degree heart block. What's the most common cause?
No oxygen?
Electrolyte?
Could be electrolytes. Most likely, electrolytes would be the problem that cause some heart block. But remember, most of our older patients, what kind of medication are they on? Either ditch or the beta blocker, right? We put most of our older elderly patient, most of our heart failure patient, right? Most of our hypertension patient, we put them on beta blocker. And what does beta blocker do? It slows down the heart rate, right? So when you're blocking the beta, then the beta receptors, that means that you prolong that. So that's why you have first degree heart block. So the simplest thing to treat them is to review the medication list. Oh, they're on on beta blocker. Maybe we should cut it in half, right? So at the same time, since we're talking about pharmacology, and think about pharmacology a little bit, how do you know the medication is the beta blocker?
The all.
Okay, the all-law medication, right? The simplest thing for you to remember is the all-law family. So if your patient on the all-law medication, that's the first thing you really have to look at it. And now you know the adverse side effects. If your patient has first degree heart block, you got to probably think about your all-law a little bit. Maybe we got to cut it back, maybe we have to stop them, or some sort, right? Now, second degree heart block, during the old day, we call winky bog. Then a lot of terminology for that. They call winky bog, they call Mobitz type 1, they call second degree type 1. I don't know. I get so confused what they call them. But usually the PR interval are not constant. They get longer, and then they lost the QRS. So what does that mean? It's the communication in the atrial getting longer to the AV, to the AV node. So you take longer, and then once in a while it won't talk to the ventricle at all. So that's why they call it first degree Mobitz type 1. Again, this is the type that a lot of time we don't treat it either. Only time we treat it would be when? If it's symptomatic. Okay? And then the second degree heart block, this is where the PR are the same. You have P wave are continuously the same, but the problem is they won't talk to the ventricle as often as they should be, right? So you keep losing the QRS. So you can see a lot of P's on your strip. If you talk to the doctor, they probably call it 2-to-1 AV block or 3-to-1 AV block. That means you have 3 atrium beats and you have no ventricle beats. So that's what they call 2-to-1, 3-to-1, and you say, I didn't learn that, but that's what it means, second degree type 2. Okay, so that's what they would call. They call AV dissociation. Okay, whatever that is. But in the nursing language, you call second degree type 2.
What would cause the random drop?
The random, again, a lot of it gets to do with electrolytes. Lots of it gets to do with electrolytes. Especially with dialysis patients, is if you have hyperkalemic, and then you got first you go into a heart block, you go to the second heart block, and then pretty soon you got to go into third because of the hyperkalemic. Because remember, potassium is very important. But if you have high potassium, then now
is it usually the potassium that throws it off?
Usually
sodium or calcium that we're affected?
Usually potassium, but calcium sometimes has some effect to it, but potassium is the biggest one. And then you go into a third degree heart block. This is the atrium and the ventricle are not talking to each other at all. We just randomly catch each other and fire.
We had a guy yesterday come in with potassium level of 10.
He got heart block, doesn't he?
You should have seen the EKG was all over the place.
Yeah.
He actually coded.
So, and then third degree heart block, this is where, you know, the PR and the QRS are not correlated with each other at all. They just rise whatever. So let's practice a little bit. So let's look at this rhythm. First, what do we have to do first?
Rate.
So look at the rate. So can you guys look at the rate? Let's see. No, look at the rate. What's the rate? How many big boxes? 1, 2, 3, 4, 5, 6 boxes. So what's the rate? Huh? 50, right? Good. Now, how about look at a P? Is there a P in front of the QRS?
Yeah.
Yep, that's a P in front of every QRS.
Yeah.
Okay, what's our P? Yeah, are they look the same? Yeah? Okay, so what's your PR interval? Is it smaller than one box or bigger than one box?
Bigger.
It's bigger than one box.
PR interval?
One
It
box.
looks like one
Big
box.
box. Big box. We're talking about big box.
One box.
It's one
No.
box.
Huh?
Looks like 4 small.
Yeah, look like 4 small boxes. Look like, but definitely smaller than the big box. Yeah. So what do we call that?
Normal.
You're talking about peak to peak, right?
From the
Normal.
start from the P
Start
Yeah.
at peak.
to
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 the,
the R. Okay, so it's right here.
so it's not one box.
Huh? From starting of the R.
It's like 4 small boxes.
Okay? So that's like 0.16, right? So 0.16, is that a normal PR interval? Definitely a normal PR interval. So you call PR 0.16, it's normal, right? Now let's look at the R to R, just kind of eyeballing it. Do you think it's regular or irregular? Regular. So you definitely know that, is this strip come from the sinus and from the SA node or AV node?
The SA.
Definitely from the SA node, right? So, but you know, so they're from the SA node. R to R is regular, so you call regular sinus, okay, rhythm. But the thing is, the rate is 50, so we call bradycardia.
That's great.
Yeah?
So it's sinus brady.
Sinus brady, yeah. Or if you want to be really specific, then you call normal, regular sinus brady. Right? It's regular.
You're gonna die.
And it's okay, now let's look at the
Not my
script.
department.
How many big boxes is there?
I don't know.
Lord have mercy.
2, 3.
3.
Look almost like a 3. It's between the 3 or between
Yeah.
14 boxes, right?
Yeah.
Yeah, so like I said, the most accurate way to do is divide it up to 1500. Right? So because you know you said, okay, it looks like it's between 3 and 14 boxes. So I would say go with the 14 boxes. So what would be the rhythm? I mean rate. Huh? 107, right? So that's our rate. Now look at your P wave. Are they in front of the QRS? Is every QRS have a P wave?
Yeah.
Yes, right? So now, is all the P wave look the same?
Yeah.
Yeah.
Yep, they look the same. Now let's look at the P wave. Are they bigger than one big box or smaller than one big box?
Smaller.
They're definitely smaller. They almost look like 0.12, right? And would that be a normal PR interval? Yes? Okay. So that's why now we call it is normal, is regular. Is it from the SA node?
Yeah.
So we call it sinus. And it's greater than 100, so we call it tachycardic, right? Usually, let me go back on the Brady a
So
little bit.
that is sinus.
Usually with the bradycardic, again, when do we treat bradycardic?
Well, it's systematic.
Only when symptomatic. When is it normal for people to have bradycardia?
If they're
Yeah,
athletes,
the athletes. And those people that, you know, they work out a lot, they do have bradycardic. That's very normal for them. However,
Pacers too. Great.
well, if patients have Brady, I'd be worried.
yeah.
Yeah, that means they're not talking to each other. Okay? So, you know, but definitely bradycardic is only people who are really fit and then they have bradycardic and that's when we don't treat. Or, you know, patient who coming in the hospital, if they're coming in the hospital with bradycardic, what do you guys think? They gotta have symptoms, right? So we don't come in the hospital and say, I have bradycardia, right? So if they come to the hospital with bradycardia, they must have symptoms. What would be the first thing you do when the patient comes in the hospital who have bradycardia?
The oxygen.
Huh?
No, take their pulse.
EKG and vitals.
Yeah.
Find out what it is.
Okay, you can take your do your EKG and do your vitals and see if they in cardiogenic shock or not. That's a good way. And what's the first thing would you do? What would be the next thing you do?
Bullets.
Fluids.
Put them down.
What do you think is the main cause of bradycardia?
Asking them to use the bathroom recently?
Remember our elderly patient again. What's the main cause of their bradycardia?
The meds.
Usually it's their beta blockers. You have to review the meds. Okay, that was the first thing the doctor is going to ask you. What do you think it caused this patient to have bradycardia? I don't know. I look at it, this old patient was on a couple of 100 milligram POBID. Oh, now we have a cause, right? So usually, that's what we do. We just have to look at the list of the medication first. That, say, hey, what caused this bradycardia? Of course, the vital signs and the EKG would help too. But that's what I would do is that, is to look at the medication list first. Because a lot of time, a patient, you figure out the medication, all you have to do is hold the medication and that's the treatment right there. And wait it out. Unless the patient can become hypotensive, then okay, we'll give some vasopressors to support that. But most likely, we just hold the meds or we cut the meds in half or whatever that is. That's why it's so important when you get the beta blocker. A lot of the doctors write orders, well not a lot, but some of the doctors write orders. In theory, when do you hold your beta blocker?
When your blood pressure is, when you're hypertensive.
What it was number one thing that you say, I gotta hold that beta blocker? Huh?
Heart rate.
Heart rate less than?
60.
Okay, in theory, that's what they say, less than 60. But a lot of time the doctor say, okay, hold if less than 50. And then what would tell you that it's safe to give is that what I always do, if my patient heart rate like in the 50 and 60 all the time, and I'm like, am I going to give this beta blocker? Is that I go back and I say, okay, yesterday when they gave it to this patient, a couple of hours later, what happened to that blood pressure? Right? Because, you can give the beta blocker with a heart rate less than 60, between 50s and 60s, unless the blood pressure is stable. So that's why it's so important, and, you got to look at the trend in the back. Because, sometimes it do more harm if you hold the beta blocker. Why do we give the beta blocker?
Slow down.
Not just to slow the heart rate, but what's the purpose of it? What's the real purpose of it?
Blood pressure.
To do what? What's
To
the
allow
real?
the heart to fill up with blood.
Well, allowed to build up, but why is it so important to allow for that feeling though?
Increase cardiac output.
We want that contractility. So that's why the beta blocker is not just slowing down the heart rate, it's not just lowering your blood pressure, but the key thing is to improve that contractility. So that's why it's a lot of time, especially with heart failure patient, if you hold that beta blocker, you will decrease the contractility, you will decrease cardiac output. See? So that's why you always have to go back and look at the trend. What was it yesterday when they took that blood pressure medication, that beta blocker medication, okay, does it affect their heart rate? Does it affect their blood pressure? Okay, so that's what it is. So first you read heart block, 99% of the time we only observe. The second thing is we go, and then the second thing is we look at their medication. Sinus brady, pretty much we just watching the patient, we don't do anything. However, a lot of time when they're in the hospital and they have brady like this, sinus and brady, that's another thing that they would do is they just you have to put what they call transcutaneous pacer. What it does is just a little patch that you put on the patient, right? It's called external transcutaneous pacer, and you just put it on it. You don't shock them, you don't pace them until they have symptoms, right? So that would be sinus brady. That's what we do. Now, sinus tachy. So when do we treat sinus tachy? Only when you have symptoms. So what would be the symptom?
Low BP.
Sinus tachy sometimes got low BP, low blood pressure. So let's think about all the common cause. What would be the cause of sinus tachy?
Fever.
Huh?
Fever.